that are in the critical access hospital category. It's always great to be able to get a project of any size off the dime, and really is just a pleasure to be working here today and have the opportunity to have the folks who accomplish a really great project. I'll be moderating today's webinar where our experts who have worked on a number of these critical access hospitals will explore some of the key factors required for the planning and design, successful execution of a new hospital in a small or rural market. Today's session hopefully will give you some insights into some of the challenges that I'm sure you all are aware of already when it comes to doing development in critical access hospital region, or even a smaller hospital that may be in that nearing that category. When you're going through the process of building a new facility, including securing financing, overcoming some of the fundraising hurdles you might face in the community, addressing concerns of the community about funds being invested, and then building really a team in that area of people who can really carry out a project often of this size, which can be a very large project given the area that you're in. On the webinar today, we'll get to hear from Michael Killian, who's had the opportunity to work on a number of our projects across the country that were in the critical access category. He's been a project executive with Hammes Company for a number of years, and I'll let him give you his background. Bob Milvey is also a vice president for Mongen Health System, Mongalia Health System in West Virginia, and we had the opportunity to work with him as well in the design, planning, and construction of the new Preston Memorial Hospital. The magnitude of this project was really unlike any that Preston County had seen before. Largest single investment certainly that Preston had ever made, and one of the largest investments really in that community from a development standpoint. Michael and Bob hopefully will give you their introductions here and talk about the challenges and solutions behind this really very visible and at sometimes scrutinized medical center. During the webinar, all the attendees will be muted initially just to avoid some background noise and ensure that we can move the webinar efficiently. Please utilize the questions feature in the webinar control panel on the right-hand side of your screen, and we will be happy to get to those questions. I think we have plenty of time today to handle questions, so hopefully you'll have plenty of questions. And if not, I already have some that have been sent in by the panelists, and we'll get to those at the end of the first presentation. So I'll pass it over to Michael, who will begin the introductions, and look forward to having all of you joining us for the next hour.
Thanks, Rex. My name is Michael Killian. I'm a project executive with Hammes Company. I've served in this role for just under 10 years now. I have about 20 years experience in the healthcare development, construction side of the business. Over the last 5 years, I've had the opportunity to work on 4 critical access hospitals. So I've led the planning, the design, the construction, and the move-in process for these facilities. You know, and honestly, over the last 20 years, the critical access hospitals to me have been some of the best projects. As Rex mentioned, the project that we'll focus on today, Preston Memorial Hospital, was really the largest project that county has taken on. So a project of that magnitude is just huge for the community, and it really means a lot to the people. So it's a real fun process to me, and it really makes a difference. Bob?
Thanks, Michael. My name is Bob Milvet. I'm the Vice President for Physician Services at Mon Health System, and I had the wonderful experience of being the Chief Financial Officer at Preston Memorial Hospital, obviously going into more detail about later. I have a lot of experience in the West Virginia healthcare system, over 18 years now, in multiple financial leadership roles. Probably the best opportunity I have outlined on my resume is this Preston project. Critical access hospitals are vital to the West Virginia healthcare marketplace, particularly as we became a Medicaid expansion state. And however you want to look at this, good, bad, or indifferent, we have about 300,000 people in the state of West Virginia enrolled in the Medicaid program, and about 150,000 of that came from the onset of the Medicaid expansion exercise. So really, it's a vital part of who we are in the state to have access to these types of facilities in these rural communities. And I really look forward to talking to you all more about the challenges, the pros, the cons, and everything in between for this project. So that's who I am, and look forward to talking to you all. Next slide. Talking about a few key facts, jumping into the presentation. Obviously, a nonprofit critical access hospital situated in a very small community, Kingwood, West Virginia. Like many critical access hospitals and other healthcare systems, our mission is to provide exceptional healthcare. Hard to do that in a very old facility. You'll hear more details about that later, and many of you can probably appreciate. So we really needed to focus. If that was true to our mission to provide exceptional healthcare services, we really wanted to do that. We just didn't want to say it. Our next hospital, over an hour away, door to door, hospital to hospital. And these are on 2-lane mountainous terrain roads on a good day. So we are at a higher elevation in Kingwood compared to the hospitals in the urban area of the state. So on a bad day in the middle of February, it could be 2+ hours to get to medical services if Preston Memorial did not exist. Vital to continue on the path of getting health care protected and preserved for the next several decades for our community. And today, I'm proud to mention that Preston Memorial is one of the leaders in many categories, financial, quality, and otherwise, in the state of West Virginia rural healthcare system. There's about 20 critical access hospitals in the state, and Preston is hitting a lot of the top indicators. I'm saying probably 1 or 2 now top in the financial indicator marketplace for the critical access hospitals in the system, in the state. Next slide, please. So we talked about, and I talked a moment ago about an older facility. This facility originally was an idea back in 1953, and many community members from 1953 can remember talking about how important it would be to build a hospital and the challenges they faced in 1953, financing, community support, whether or not they were able to make this dream happen and become a reality. The list went on, and those experiences from 1953 were very similar to what we face today. 1955, the original Preston Memorial Hospital opened and provided access to medical services for 60 years. With that said, jumping into the drivers, before I get into the market factors, etc., the obsolete facility, obviously, we had to do something. It was a matter of time as a CFO where I tried to tell my board and explain, if we do not replace this plant, we're going to be investing millions into the roof, into the elevators, into the kitchen, into whatever it may be. It just started to become a very ugly facility inside. We were catching water that was leaking into 55-gallon drums that we had in the hallways. We had just a tremendous amount of disrepair inside, but the outside of the facility really didn't look that bad. And I'll talk a little bit about that in a moment. But our market factors were, because of the dilapidated, old-looking facility, our inpatient factors were very limited. We were seeing a census of about 5 in a 25-bed facility. So we had a market at the time that we were still trying to keep some outpatient business growing, but really outpatient was flat and declining. We were only doing about 30 to 35 surgeries, and we were down to about 100 deliveries in our birth center. And we decided we had to make some serious changes, or market factors were probably going to put us out of business. Volumes, as I mentioned, were a challenge. Our competitors, the Mon Health system, Mon General Hospital, that we're now a part of, we thought was a competitor, is now a partner, but we also have a large tertiary university academic healthcare system an hour away from Preston Memorial, and they were interested in putting clinics, outpatient clinics near our hospital, presenting the scenario that perhaps Preston Memorial didn't need to exist. If they could capture all of the outpatient business and just shift all of the referrals off the mountain to their hospital, then perhaps this old facility didn't need rebuilt. So it was up to us as a key driver to make a very big business case and try to even determine if there was any community desire whatsoever to allow for another 3-4 decades of access to medical care in our community. Those were the key drivers that we faced when we went through this decision. And these were similar drivers back in 1953 to 55 when I talked to some of the older members of the community who were very good guiding points and mentors for me as we went through this exercise together. Next slide. So obviously we said already the single largest investment in Preston County history. That's a fact. Yes, we did the facility back in 1955, but not to the magnitude we're faced with today, not a $38.5 million initiative. This put Preston County on the map. It's the newest hospital in the state of West Virginia. There are about 55 facilities throughout the state, 20 of them critical access. Preston's now the newest in the state, and it has got a lot of positive press. We initiated the project back in the spring, of 2010, and I started at Preston in 2009, and I understood the conversation had existed a few years prior to my arrival, but had really died. The hospital wasn't doing well financially. The board just couldn't find its way through affordability to make this happen. So the project itself kind of stalled for a few years until the spring of 2009 when we relifted it. 3 years later, we broke ground right before the winter season started, and we opened our facility in May of 2015. We remain a 25-bed private room critical access hospital. It's 80,000 square feet roughly. Expanded the facility to include very nice modernized physician offices, outpatient PT. We have a very smart operating room suite, smart technology throughout the suite, much more updated and upgraded from an equipment standpoint. The ER was a 5-bed ER. We expanded it to 8 beds. Improved our laboratory services and access to the lab, diagnostic imaging, and just more robust outpatient services altogether, which at Preston, 80% of its business, which is a very high statistic, but 80% of its business is outpatient. So to really create and open up access for our growing outpatient needs in the community was very important for us. And then finally, the key project fact that really was important to us was designing a facility that had clinical adjacencies in mind. We had, as you can imagine, not just a 60-year-old facility, but very inefficient in many ways, including utilities, et cetera. But getting a patient from one point to another was very inefficient. If you looked at our dietary services, getting a meal to a patient room, we had to leave a kitchen, go through multiple doors and wings to get to a public corridor, into an elevator bank, up an elevator, into another public corridor, and down a long hallway to access a patient room. And we cut many steps out of that equation when we focused on clinical adjacencies, whether it be for dietary or for housekeeping or getting a patient from the ER all the way back to an inpatient bed was what we had kept in mind to keep the footprint as small as possible, affordable, but making sure there was a tremendous amount of efficiency within that facility, and we accomplished that. Next slide. Of course, sounds easy, but not. Many challenges along the way. This one-page slide attempts to identify a few of them. There were several hundred along this journey. But not to scare anybody, it was absolutely at the end of the day the most important thing we could have done. But no, when we went into this project, and I'm sure many of you will experience this if you're entertaining this, where were we going to get the land to build a facility? We were very lucky that we had the county support to donate us land. We were able to receive about 30 acres of land to build the facility, but of course free land comes at a cost. It was a hillside that presented many landscaping, architectural, engineering, design challenges, but it was free land and we had to deal with that. Our population is aging. We're dealing with a growing double digit greater than 65 years old, influencing what type of care we should be providing in this design. We just didn't want to build a facility that took care of every need in the county. We knew we had our limits and we had to focus on our demographic. We know that in the next 5 to 7 years we're going to continue to see double-digit growth in 65 or older population. Financing challenges. When I took over the facility in 2009 as the CFO, we were counting the days cash on hand in hours. I mean, I think at one point we were just shy of 2 days cash on hand, $900,000 of held checks. We were late on just about every bill, 6 months behind on paying health insurance to doctors' offices and hospitals in the community. We had a really tough situation on our hands and didn't know if we were going to be able to pull this off. Didn't know if there were local contractors or business people that could help us. We wanted to make sure we as leaders really understood and engaged with our clinical personnel, talked to our doctors and our nurses. What are they looking for? Do they really believe we can do this? And if so, what type of facility would they like to be? Our community engagement. I hope you don't experience this, but we at some point along the way identified people in the community who felt it was not necessary to spend any money whatsoever, and maybe we just closed down our facility altogether. So we had to deal with political agendas. We had to figure out how we were going to get fundraising and capital into this project and try to make a case that this was worth its weight. Determining the right size of the facility, the location, the access, given the free land that we had, how are we going to build a facility that would work? Not just any facility for the sake of building something, but for the sake of answering the question, why do we want to do this in the first place? And that was to provide decades more of access to health care in Preston County. But finally, I will tell you, this was so important for my CEO and myself. We had to be very honest. We did not know how to do this. We've never done a project like this before, both of us. We had to lead and navigate our board, our staff, our clinicians, our community through an exercise where nobody has done anything like this before. It was very important to us to be very honest about that, put our egos on the table and say, forget about it, let's get some help, and determine how we can get the right people around the table. If we're serious about this and committed, and we're going to try to turn this ship around to a new hospital, then we really needed to ask the right questions and seek the necessary guidance to complete this exercise. Next slide. Michael, I think this is yours.
Yep, agreed. So what we have here, we start talking about team building. So Preston Memorial engaged our firm for their project in 2012. So one of the first things that we want to do when we get in there is really start thinking about the right team for this mission. You know, and one of the things that I would imagine it would almost be like being a general manager for a professional sports team. You've got a mission, you have to assemble a team. Maybe my salary cap is slightly lower, but you're doing the same thing. You're finding the people that can deliver a service. So key with these projects, of course, is accessing local resources, and we'll get into that a little bit later. Planning and building the right project for our community. So what we're talking about there is we want to make sure that we're sensitive to the community and their feelings towards the cost of healthcare. The smartest thing to do typically is to make sure your dollars are going towards patient care areas, not necessarily towards a facility that might end up on the cover of Architectural Digest. So it's really key to understand the community and realize what their expectations for a new facility are going to be. Third bullet point we have here is executing swiftly on the construction side. And what that means really to us is you want to show the community that this project really is happening. You know, there's not many more frustrating things than to either get stuck in a planning process or maybe start a construction process and then pause it. When you have everything planned out, you kind of want to hit that button, so to speak, and move ahead. Next slide. So now we will get into our top 5 factors. Our team picked out these 5 factors, and we think they're really the key to really ensuring the project's success. Many of these factors kind of overlap. We're going to hit all of them, but we think if you focus on these, you're going to end up with a good project. Next slide. So we wanted to give you a little bit of an overall feel here for the project schedule for Preston Memorial. And Bob kind of hit on it a little bit. The project initiation was really 2010. We put this schedule together really when our services started in 2012. And I'm not going to get into a lot of detail, but one thing I do want to make note, it's kind of got a light gray line almost in the middle, really 40-45% of the way. What that represents, everything to the right of that line is really the construction. Everything to the left of the line is planning or pre-construction. So I think it's important to note that a lot of this effort is really planning. It's really critical to identify what the new facility wants to be, what the new facility can be, and really get everything lined out and, you know, quote unquote, all your ducks in a row before you start the construction. Once the construction starts, you know, a phrase that we've used really before is, you know, the table is set. You've done a lot of the work. Everything's ready to go, and you get moving with construction. Next slide, please. Bob, I think we're back to you on this slide.
Sure. Thanks, Michael. So rolling off of the top 5 factors, just starting with finance, when we started this exercise together, there are many variables happening within our financial structure, including a very difficult challenge with respect to, you know, the question of whether or not critical access hospitals were even going to remain in existence. And many of you know that in many ways over the past several years, Congress has tried to eliminate, including in the Budget Digest, eliminate the critical access hospital designation. So that was a question mark. If we cannot have our critical access designation in a very overwhelmed Medicare, Medicaid, self-pay population, could we even entertain an exercise like this? I presented a possibility to maybe evaluate Chapter 11 reorganization. Our financial situation in 2009 was dire. I talked about the held checks, the limited days cash on hand, a little bit of debt, but not much, very aged facility, no ability to invest in capital, lines of credits tapped out, inability to meet payroll. The list went on and on and on. I had asked the board, though, to give me an opportunity as the new CFO to put together at least 18 months of a financial reorganization strategy that was quite painful in some ways, but very successful ultimately. We were limited in what we were doing in our general surgical capacity, so we really had to start evaluating. If we're going to do surgery, let's focus on the things that are needed. We can do well here and recruit some general surgeons. We were successful at that. We had to be very honest about the ability to continue delivering babies with a growing, aging demographic and births now falling near 100 or less on an annual basis. It was very difficult to recruit and maintain a quality birth center program, so we closed our birth center. We had to renegotiate our managed care contracts as best we could, which is hard as a small little facility without a lot of leverage, but we were able to pull a few chains here and there to make that work. And when we identified some other non-performing assets or things that were just out of sight, out of mind, like home health care, getting out of that line of business and not focusing on things that kept us as administrators sporadic in our day-to-day work. So we tried to focus on our core and get ourselves back on track, and that happened. About 2 years later, we had really nice financial success, double-digit operating margins, cash was starting to come back into the bank, and we were able to perform a financial examination necessary to suggest we could take on some of our own debt. Not all of it for the project, but some of it to apply for some money that was available through the USDA Community Facilities Loan Program. Next slide, please. And what we identified in this financial examination was that we were able to qualify with our recent albeit brief, financial performance history, a examination projection and the work that we had built into our strategic plan for the next several years. The examination report suggested we could qualify for about $26 million of debt, and we knew that looking at our project budget, that wasn't going to cut it. We had about a $38.5 million price tag at the end of the day, so we were still short. But we qualified for a $26 million 35-year loan at 3.5%. 12.5 of that we were able to apply with a local financial institution at just over 3.6, actually 3.65% for a total capacity of 38.5. We still wanted to raise money from our community. We wanted to do an ongoing capital campaign to help with our debt service or help with buying equipment to maybe limit the debt a little bit. At the end of the day, we didn't utilize our full borrowing potential. I'll talk about that. And something that was very important to us, we were not able to, even though we qualified in the examination report to afford $26 million in debt, and a local bank agreed to come up with the delta, the 12.5. Nobody would close this deal unless we had some type of guarantee from somebody. And we already talked a little bit about the dynamic with our university healthcare system. We didn't want them closing our doors and just putting outpatient clinics peppered throughout our community. We felt it was appropriate to find a partner who believed in us, who engaged in us, who felt we were necessary in the community to help keep patients closer to their home. And that's our new partner, the Mon Health System. It's an A-rated, A- rated healthcare system here in West Virginia, about an hour away from Preston. And they decided to partner with us on a full merger type partnership to basically guarantee the debt to enable us to close the loan for this project. Next slide. So, public disclosure on our finance section here, we did have a budget that was scrutinized. The community is asking questions. Why are you wanting to build and spend this much money when we're hearing everything on the news that the cost of care is already out of control? How does this do anything to eliminate the cost of care, or reduce the cost of care, rather? People saying your building looks nice on the outside, why don't you just spend a little bit of money to freshen it up on the inside? But none of that was really possible. We had to present scenarios that proved we could spend millions of dollars a year over the next several years of money we didn't have to try to replace the boiler system, to try to renovate an existing plant that would be very disruptive, to try to redo or upgrade our technology that may not really work for us. We had to prove that that was more expensive in the long term than building this new facility. And we just had to be very sensitive. If there's any money that was unused, how would we convey that? What would we do with that money at the end of the day if we were under budget? Because in hindsight, we were challenged. I was challenged a lot. The project was $1.5 million under budget. And as a CFO, I was very excited about that, but others asked, what could we have done had we used that $1.5 million? Could we have done something more aesthetically pleasing to the facility? Did we scale back on anything that could have generated more revenue? But throughout this exercise, we really didn't know the end game, the end result, until the end. So we had a tremendous amount of support with Hama's company and with our other members of the team to identify, don't scale back the facility and eliminate any revenue generating functions. Keep the same footprint, but narrow the amount of administrative space. Narrow anything aesthetically that we don't need. We'll talk about that in a little bit from a cost control standpoint. But it was very important to show, even though we ended up with $1.5 million left over, we did a very good job of maintaining a footprint that would satisfy the needs of our community for many years to come. Next slide. We also had to be very honest. Outside of financing, we still wanted to raise money. We wanted the community to be connected to this project as much as possible, but we never really ran a campaign before. Just like not building a facility, we wanted to talk about raising millions of dollars to help put down on the debt if we could, or buy new equipment if it was above and beyond the debt we could afford. But we never ran a campaign, and we knew that selling cookies or bake sales or having little drawings and things along the way just weren't going to cut it. We needed to hire somebody who knew how to have private one-on-one meetings with people in the community that we've never even talked to before. Maybe getting mailing lists of people who were 65 and older and owned a lot of property. It's a very large farming community. People have several hundred acres of land with natural gas rights worth several millions of dollars. And when we started to tap into these resources, we identified very quickly $800,000 raised in the first year alone of the campaign, and that campaign remains successful to this date. We had to stay in close communication with community leaders, people that may never have been on our foundation board or hospital board before, but we knew they were invaluable resources. Some of them we just never had relationships with before, but we had to talk to others about accessing people who could help us. And we found them. We found people. One lady lived in Texas, and her daughter had care at Preston Memorial 25 years ago, and she ended up giving us $150,000. So things like that, we didn't even know this person existed had we not gone out and asked questions. We just really had to break through many barriers to reach across new audiences, because the current audiences we felt and we believed weren't the audiences that were going to get us to the next level. And while that hurt some feelings along the way, it was necessary long term to make this work. Next slide. Our community, it's a very remote community. I talked about that earlier. 2-lane roads, only 2 of them that get to the hospital, mountainous terrain, very windy, high elevation, a local community of about 6,500 in the town of Kingwood and immediately surrounding towns, but a population 30,000 total in the entire county who are very passionate about themselves, their access to medical services. They're very prideful, conservative people. But everybody recognized how far away it would be if Preston Memorial didn't exist to get help. People would die if they couldn't get access to emergency medical care in the middle of winter. And that was period, end of story, a major selling point for us that people really gravitated to and believed. It's a very older community. We have a duty to take care of these people. Many of them can't get out of their homes in the winter. When Hurricane Katrina came through several years ago, you saw a lot of noise on CNN about what happened along the eastern seaboard. What you didn't see was what happened in Preston County, one of the hardest hit counties in the nation, where people were buried without power for almost a month. These are people who in their 60s, 70s, and 80s couldn't get out of their homes. And the desire to use our facility to help support them, to get them out of their homes, take care of them, feed them, medicate them, was very important. We did a community health needs assessment. We talked a little bit earlier about how we had to identify what the real needs were. We can't be everything to everybody in our community, but we knew we could build a facility that would benefit those within our need assessment portfolio, and we paid very close attention to that. And we are in a border community area. We border the state of Maryland and Preston County, and we really wanted to control out-migration as much as possible to keep people from having to leave the state for health care outside of the walls of West Virginia. So that was very important to let our community know we wanted to be there for them so they didn't have to go elsewhere. Next slide. Very important things to mention here within our community as well. We wanted to show that we were able to build a creative financial mechanism that had basically a 3-legged stool. I needed some debt, I needed some cash, and I also needed some fundraising from the community to help make this thing work. So a lot of different areas of access to money was how we pulled this thing together. Initially, when we looked at this exercise and we saw that we were $12.5 million short, we wanted to have a special election in our community to go ahead and do a tax levy, a property tax levy on the people of the county to help build our hospital. And we felt that in a community that hasn't passed a levy since 1984, that this was not going to be a very successful exercise. Also, we were competing with the school system. The schools were very aged as well in the facility, very hard to attract young families. They were going to put on the ballot a special levy to go ahead and raise property taxes to build some new schools. And the last thing we wanted to do was put that competition on the ballot. If we were to win the ballot as a hospital, it would have been at the cost of the education system. We just didn't want to do that, and we decided we would look at alternatives other than a tax levy. And we coordinated with several people in the community to make sure if we're not going to do the tax levy, we still need support to make this happen. It was a very, very critical period of time for us to know that we were not going to have this levy available to us, and in hindsight, the community at large greatly appreciated our choice to support education, which we ultimately feel could improve the economy inside the county and getting people to relocate and move there, which would ultimately use our healthcare system. Next slide. Michael, you want to talk about the team?
Yep, thanks, Bob.
Yep.
So a little bit more on team. We've got this slide broken out into 2 parts, really: consultants I'll classify as primarily team members that are going to be involved on the front end before construction, architects, engineers, surveyors. And then I've got project delivery method, really dealing with the contractors and subcontractors. So when you engage in a project like this, there is a lot of interest in the local community, and that's definitely a good thing. And in a lot of the communities, we have found that there are a lot of good qualified tradespeople that can work on these projects, and there are also some people that just don't have the required expertise. So I'm going to first talk about consultants. From our perspective, really, anyone dealing with the building itself, not necessarily the site, but the building, it's really going to be to your advantage to have a consultant that has healthcare design experience. You know, it can be as little as working on a renovation on a hospital to as much as designing, already designed a few of these hospitals already. So starting with the architect, I'll continue kind of with the football ball analogy. We might want to call the architect kind of the quarterback of this process, of the design process, really. So I think it's important to get not only an architect with healthcare design experience, but at least rural healthcare design experience. I think there's, when we get to the program piece, you'll see there's just a model, a key model that really flows through the critical access hospitals, and they're all different with adjacencies, and some hospitals prefer to focus on different parts and pieces, but I think with the architecture, it's critical to have someone that has a few of these at least under their belt, so to speak. The third bullet point I've got under consultants really is balance the need for specialty consultants. On a lot of projects, the example I used here, we use enclosure consultants. I think Bob mentioned earlier that their current facility or their previous facility, in some instances they had 55-gallon trash cans out in the middle of the hallway collecting water. The last thing we want to do is build a new facility and wheel out a 55-gallon trash can in the middle of the hallway to collect water. But if you get the right consultants on board, for Preston, we had an architect that was very savvy with their enclosure details. So in dealing with them, our team had a big comfort level, and we said, you know what, we can save some money here and really minimize the need for an enclosure consultant. So as you're dealing with your various consultants, if you get the right team members on board, it might mitigate the need for a whole team of consultants. Project delivery, another important factor here. How do you want to do this? On all projects, there are multiple ways to deliver a project. For Preston, for a few key reasons, we decided that GMP, or guaranteed maximum price, was the way to go. So what that process is we really interviewed and priced out a set of the design documents before they were complete. We got a comfort level with a construction manager that Preston wanted to use, and we invited them to be part of the team. So they were at the table with the whole team during the design process, really, buying into that process, taking ownership of the project themselves, providing us with great cost data, and also as part of that, the benefit there is the owner has a lot of control over the subcontractors and what subcontractors are used in the project. The community gets so excited about these projects that once you actually start to move dirt and once construction progress actually happens, you'll have community members, like it or not, coming out to the site to look. So ideally, everybody parked in the site, it'd be great, for Bob in the state of West Virginia, you want that parking lot full of people working on that building with license plates from the state of West Virginia. So doing a GMP allowed the owner to have a lot of input into the subcontractors, and you have the opportunity to really determine if those subcontractors are qualified. Next slide, please. So programming. the critical, I'll call it the critical access hospital model. The various critical access hospitals I've worked on have similar chassis, I'll call them, 25 inpatient beds maximum, emergency department, ORs, imaging department, all the different support spaces. I think that model is very similar from hospital to hospital, but in Preston's case, as opposed to some of the other critical access hospitals I worked on, they had a large surgical volume, so they wanted to, to really focus on their ORs, whereas other hospitals I've worked on, have not really necessarily focused on their ORs, but maybe they focused more on some of their inpatient rooms. So hospital to hospital, that model definitely can flex, but there is definitely a base model that you want to use. Right sizing. When we get into that, we're talking about the individual spaces. And, as most of you know or will come to know, that with these projects, really square footage equals dollars. So you want to make sure that your facility is going to be very efficient. At the same time, you want to make sure that your facility, when it opens, is going to be right-sized. For Preston, as an example, they were able to afford slightly larger patient rooms. Their patient rooms are just outstanding. Nice, large windows, a lot of natural light, a little bit of extra space for the family. So I think that's a huge patient satisfier. At the same time, you need to balance the design and know as an owner to push back on certain spaces. There are code-dictated minimums for certain spaces that you need to meet. Sometimes consultants or design team will go over those minimums, and I think sometimes that's a great thing to do. And other times you kind of want to toe that line and make sure the space is really efficient, really, so you can meet your budget and not spend money unnecessarily. Last bullet point on this slide for program: eliminate scope creep. Typical in a lot of projects, but once you go through that programming effort and everyone is very comfortable with that program, you probably have another, anywhere from 9 to 12 months of design. So you can't just put that program back in the shelf. You got to keep it out, and you got to get it out, and you got to check what your team is doing as compared to the program. That's really a big part of projects that can be derailed. You, as an owner, if you've already spent a lot of money assembling a team, designing a project, and then you get to the end point where you're going to get your dollars from a contractor, if you're not really staying on track with that program, I've seen a lot of projects either get shelved or not move forward at that point, simply because people aren't really looking at that big picture. Where do we want to be? Where do we need to be? Next slide, please. So challenges and solutions. We just wanted to throw one out here for that actually happened in the Preston project. As I was mentioning, we did the guaranteed maximum price where we had the contractor at the table. When we're finally, at the end of that process, we get the final number from the contractor. And at this point in the process, really where you are is everyone's excited. You've been meeting for 9, 12, 15 months. Groundbreaking is almost imminent. And frankly, you're almost getting tired of seeing the paper, and you want to see action out there. So that's the point you are, and then you kind of get this bomb dropped on you, where in our case we're 15% over budget and we're ready to go. So solutions there. Really, what we do is you get the team together, and then you find out where you've been, and you find out where you're going to go, and really you challenge the team. How are we going to do this? This owner has a mission. We have a mission, and it's our responsibility to figure it out. So for Preston's case, and I think you can advance this here, it kind of lists some of the solutions that we came up with. Preston was really holding on to their square footage, and they were adamant, rightfully so, that, you know what, we need the square footage. We cannot cut square footage. I think an easy solution when you get to this point in a project is initial reactions are, well, let's cut square footage. Square footage equals dollars. If we need to get under budget, let's do that. But that wasn't the right solution here. So we've listed some targets that we went after. Some of them were, you know, there was a prominent building clear story that we eliminated, and I can tell you the architecture of this building is fantastic. So any of these that we deleted, I don't think took anything away from this project. Next slide. So lessons learned, and we'll list them here on the next slide. These we came up with, and I came up with some of these just from the various projects I've worked on in the last 4 or 5 years. The first one, focus your attention during the construction process. You know, when the quote-unquote table has been set and you push the button and you go, there's an awful lot of work to be done. You're probably dealing with anywhere from 30 to 40 subcontractors, and you know, with any team, you find out, you know, when the game started or the battle started, there's strengths and weaknesses, and that's always the case. So it's important to really focus on the small, I'll say, non-performing subcontractors. In one of the projects, we had a window subcontractor that just, you know, was not meeting their schedules, not going through as they indicated. So you have to stay on top of them, and you really have to look at the big picture and focus in on the details where you need to. Lead with a team philosophy rather than developing an us versus them mentality. That comes really with your delivery method too. With Preston, this was fairly easy. With a guaranteed maximum price, you get the contractor on board and you have a team mentality. Sometimes in a hard bid situation where you put the documents out and you sometimes take the low bidder, I've seen people take the attitude of, you know, this is our money and it's going to be our way or the highway, and it's going to be an us versus them. Well, what happens with all projects, there's always issues that come up. So the best way to solve those issues is if the team has trust in each other, and if you're really on the same page. So I think that's important. Realize there are challenges in remote locations. Bob touched on the remoteness of Preston Memorial, and that's been a similar experience I've had with the other critical access hospitals I've worked on. Whether it's geography, and that might make a subcontractor not be able to get to the site, whether it's weather or site conditions, there's always something that comes up in a construction process. So you need to realize that and have that built in your schedule if you're trying to meet a key end date. Documentation with local municipalities is key. This can range all over the map, and some of these communities dealing with the local municipalities can be challenging. Some of them don't communicate with email, so you really need to make sure you stay in touch with them and make sure they're at the forefront of everything. Last bullet point here, I think Bob touched on this. I don't know if you want to speak a little bit more about this, Bob, about leadership on the project.
Well, just as I said earlier, we were just very honest going into this. We knew we wanted to do this. We couldn't do this by ourselves. My CEO and I sat down side by side throughout the entire length of this exercise and realized we need expertise between us as administrators and the architects and the contractors, or we're not going to get this thing done. We evaluated several different firms to help make that happen and gather intelligence about who we wanted to use. We ultimately selected the Hamas company. Very proud that we made that decision. It got us our hospital in the amount of time we wanted to get it, under budget. We couldn't have asked for anything more, but it was very important at the very beginning of this stage, of the stages of planning, to just realize and be very honest. we're smart people. We know we are. We know we have capabilities. But at the end of the day, we have a serious limitation in building a brand new hospital, and we needed to hire outside help to make this thing happen.
Next slide.
Guys, this is Rex Holloway back on the line, and great to have any of you who joined after the webinar started. Good to have you with us, and hopefully some great background on the courage, I think, for a whole community to put one of these together. You know, I always say it's amazing we call it development. I wish we'd call it finishment, because so much never really does get finished from the stages of people's ideas and actually getting a facility into place. So when you hear a success story of a community accomplishing a facility like this new hospital, it really is a real testament, I think, to community courage in the long run. Bob, I'd be interested, as you are kind of weighing the history of even getting to the point of the original decision. You know, a lot of people do that stage of renovate versus replace. You know, did you go through a formal process, you know, just adding it up? If we were to just brighten the whole place up, keep it right in place, and put lipstick, if you will, on the original facility, did you go through the formal process of comparing those options? And if so, how bad was the comparison?
Yeah, yes, we did. That's a great question. And that was a hard sell too, Rex, because when we did the analysis, it suggested anywhere between 18 and $20 million would put lipstick on the pig. And we could do a number of different scenarios, maybe 5 million here, another 7 million later, and finish it off in year 3 or 5. What I struggled with is doing that retrofit, or putting that lipstick on, if you will, in a facility that was already inefficient. We would have to shut down corridors of the plant to make this thing work. It would be very noisy, dusty, disruptive to our entire operation. And I know that's not the entire sale, but it made a lot of sense when we talked through it to the rest of the facility. We're already struggling enough as it is to get people into our doors. The last thing we want is to make it worse, to make it loud, to make it dusty, to make it shut down corridors and access to different areas of the facility. We just made that decision. It's 18 to $20 million. I know this sounds ridiculous, but my point as the CFO was, if you're going to spend 18 to $20 million, let's just bite the bullet, do it right, at a new location, invest in the right resources and people, and let's just spend the $38.5 million to get it done right. I'm glad we made that decision long term, but the challenges along the way were, hey, we can do this thing for 18 million bucks, why don't we? And I just didn't. My gut was telling me that that wasn't the right answer.
You know, and I would encourage, if you have additional questions, I hope you'll type the questions in. We'll get those passed on me. I'll make those available for everybody. Again, we'll get a lot of this available. If you want to display it to others, we will have a link for this webinar at a later date. A couple other questions. I mean, just talk a little bit, if you could, Bob, as you looked at the amount of time perhaps you and your CEO on and the types of connections you made in the community to put this together. It's always been my sense there's probably several, count them on 2 hands perhaps, folks in a community, not always on the hospital board, that ultimately allow and make these things successful and that they can go forward. Talk a little bit about the communications planning and just the overall approach to making sure you were in the right places at the right time to make sure the key community stakeholders finally got on board. How much time investment did that take?
It was a lot more than I care to even remember. We had just a tremendous task and a tremendous amount of time invested in convincing people in the community that we were going to do this in the first place. And I'm talking our county commissioners, the people who donated us the land in the first place, convincing them that we were going to make this happen. Developing relationships with a difficult group of councilmen, city councilmen in our community who we felt along the way they just didn't even want to see this thing happen. It was very challenging, but we had to invest in those relationships to really prove that we needed and show our desire for their support. We had to engage these people. Many dinners, many overnight stays in the community. I do live an hour away from the community, so it was difficult for me. I'm not a Prestonian, as the locals call themselves. So it was a hard sell for me to come in and suggest that we should build this $38.5 million hospital, and then at the end of the day, I get to drive away and go off and do my own thing. What I found most valuable, though, is I identified a man in the community, an 84-year-old gentleman who gave me very detailed stories about memories of his father wanting to build the hospital back in 1953. And he became my mentor. He was a well-respected member of the community who knew just about everybody you needed to know and get access to. And he was probably, next to my CEO, the person whom I spent the most amount of time with. And he was able to navigate me through to the right people, whether it be the prosecuting attorney to get access to this person at the right time, whether it be a local farmer who knew thousands of people who could garner support for us. I really leveraged our relationship and developed a very wonderful friendship with this man to this day. But he encouraged me along the way. It was time well spent, but he said, look, we did this back in '53. We're going to do it again in 2015, and we did. But I can't stress enough how important it is. Sometimes it's uncomfortable. You see people out in the community. You know they don't support you. You don't want to talk to them. But at the end of the day, it was absolutely the right move. At the grand opening, they all showed up and were shaking their heads up and down with big smiles on their faces. And you know what? That's what it was all about at the end of the day. So lots of hours planned for it, over and above what you do during the day now. Weekends, holidays. Some of those will have to be consumed with this exercise if that's what it takes.
And what you, I think, also realize after you do it is that process, once you have done it for a very large critical issue like this, is you can't go back. I mean, the work
Right.
continues on with those key stakeholders and making sure that you're never in a position where you don't have their input, even if they're not on your board, because they often do drive a lot of the key community health initiatives.
Yeah, they all have strong, deep relationships that I'll never even begin to recognize or figure out how they started. But it's just fascinating to see how many people so deeply connected in that community. We had to hit them all.
Talk about a little bit on the steering committee and the internal project team at Preston. How did you find day-to-day the amount of time they had to spend, and as they look back, any takeaways from let's call it the department managers or team members from a clinical planning standpoint and their involvement?
Yeah. Well, first of all, it's very important to involve everybody. From the initial design phase, the schematic design phase with the architect, it was important to engage every department manager, every department head and staff and physician leadership throughout the entire organization to understand what we were drawing for them, to get their input, and then to really translate that into the next document that we could start navigating through to prepare for a design development phase to hand over to the construction team. It did take a lot of time, but you know, it's necessary. It wasn't so overwhelming that people were losing sleep and losing time at their day-to-day jobs, but we committed very early on. This is the community's hospital. This is your hospital. You have to work in it every day. The last thing we want outside of having to catch water in 55-gallon buckets in the new facility is for somebody to not have a place to sit or to care for a patient. We wanted to make that very clear that you have to spend your time and your commitment and your energy in designing this thing right. And if you haven't done it before, like we haven't, let's hop in a car or a bus and go visit a few places that have done it and talk to them about how they helped work with the teams that will build this facility for them. And we found that to be a very helpful exercise to go off campus and visit a few other critical access hospitals to see what they've done. And again, back to the investment in time, it was a tremendous investment in time, but at the end of the day, everybody appreciated that. more than just having them walk into a facility and hoping that we did it for them on their behalf and it was going to work. So we were just very open and honest at the beginning of this exercise. You're going to be invited to a lot of meetings. We expect and mandate your participation because you will have to sign off on the drawings for your space at the end of the day to make this thing work.
Hey, Mike, you've done a number of critical access hospitals in not only West Virginia, other locations. Tell me how you felt this one was different in any special ways from some of the others that you've done. What were some of, at least, differences here, and what have you seen as you've worked with this team?
Yeah, I think Preston had a great team, both internally. You know, as Bob said, it takes a lot of time, and they really wanted this to happen, and they really put the time in. So that was great. I think they got a great team to design and build their facility. Also, I think the architects they used was a right-sized firm. I've worked with large architecture firms, medium architecture firms, small architecture firms. From my perspective, for critical access hospitals, the sweet spot is probably a mid-sized to small-level firm. You're going to ensure that you kind of get the A team there, whereas if you go with a larger firm, you might get their A team, or you might not. So one thing that Preston had that was really neat, you know, and again, Bob mentioned it, at the open house ribbon cutting, it's the coolest thing to see the whole community come out and support the facility and eyes wide open and just say how beautiful and how lovely it is and how thankful they are. So that was great at Preston. You know, and truly that's great. That's great at the other critical access hospitals too. The community support I see for these projects is really neat, and it's really fun for me to participate in.
One last question, Bob, and I'll get us wrapped up. Just the overall confidence in admitting patients, doing surgery there, impact on the census. You were handling an average daily census of 5 or so pre-construction. What I know you've only been open for a little while now. Give us a sense for how the census is going and the level of confidence for surgeons to admit and do surgeries that require inpatient or admit an inpatient into the facility.
It's improved greatly. So the average census is now around 13. Now, I know that sounds light, but there are heavy surgery days. We do have the only center of excellence in bariatric surgery for a critical access hospital. I think we're one of the only or one of the few in the nation at that level. And those heavy surgery days, the Monday, Tuesday surgeries, the hospital's full. So we typically see 22, 23 patients in the hospital those first few days, then it dips back down into the 8, 9, 10 range. But yes, absolutely, we're seeing an average census now of about 12, 13. The ED is seeing about 1,000 patients a month now, which when I left, it was probably hovering around 750-ish range. Surgeries are about 100, ranging from 110 to 130 in that range, give or take, every month. And the outpatient visits, the physicians that are speaking that are the happiest right now are the physicians in the outpatient specialist center. They really believe we rammed home the right design. We're seeing about a 10% pickup in our outpatient visit census right now, and it's just the design itself is really helping get more patients in and out of the clinics more efficiently, and we've received a lot of good feedback about that. The hospital closed its year. June 30 was its fiscal year end, so a month and a half after it opened. It closed its fiscal year at about $2.2 million net income from operations, and it's off to a fantastic start right now, 3 months into the first quarter of this new fiscal year. And if they broke even the rest of the year, they will have hit budget already. So they're doing very well. Census continues to pick up, and one thing that's very nice to say about our relationship inside the health system, if other hospitals have an opportunity to do this, when we merged with the Mon Health system, we made it very true to the community. If there are patients that are admitted to Mon General Hospital an hour away that have a Preston County zip code and could be taken care of in Preston County, that we were going to put our hospitalists up there in that new facility and keep those patients in that hospital, and that is happening. So it's not just the community admitting or the surgeons being comfortable doing procedures there or the ED. It's really a matter of getting those patients back home and having a relationship within our system to make sure the care can be provided locally, and that's definitely helping the census too.
Any new physician recruitment been enabled by having a great new facility and or key staff members? I would imagine this is having an impact if you want to remain or come to that community from a recruitment standpoint.
Sure is. We actually recruited a general surgeon and a PCP, a male general surgeon and a female primary care doctor here in the last, well, one was in the last month and a half, the other one was 6 months prior to that. The facility, the new facility, had a lot to do with that. And we do have 2 PCPs lined up here in the next 2 years when they finish residency to join the system up there. It's also allowing us to send specialists here from the health system in Morgantown, where I'm working at now, put specialist clinics up there at Preston, and people are much more willing to go up there now because it is an efficient design. It is brand new. They like going up there. And so we have a cardiology presence now that we didn't have before that's very valuable to that facility and to the patients in the community.
Well, this has been a great session. I hope it's been valuable for everyone who is even thinking about kind of the next stages for their hospital, and I hope you'll take the opportunity to share the webinar with others. We will put the link up and make the presentation available. Bob, I personally want to thank you on behalf of Hamas Company for the partnership and the work that we've done together. It's always great when you can look back even 10, 15, 20 years later on effort that you've created like this, and it really will be, I think, foundational for, obviously, for the county for many years to come. Mike Killian, you spent a lot of time driving country roads as well and coordinating the teams in this great endeavor. So, you know, my hat's off to everyone who it takes to actually pull off a very large project like this, and all the complexity of builders and trades and architects and others that come together. So great project, and again, thank you all for joining us today, and look forward to future conversations.